I'm going to speak about something which is the bedrock, which is the foundation of what Dr. Goel has been saying. You see, this lecture is not meant for uh, it's not meant for experienced people who have been in spine surgery for decades. This is meant for a young practicing neurosurgeon, maybe a resident in training, or even a biomechanical engineer or an instrument designer, even somebody like Professor Goel, who, without these basic concepts, I'm sure Professor Goel wouldn't advance his theories the way he has advanced now and the way everybody appreciates them. So the understanding of the biomechanical anatomy of the spine, the physics of it, what is the basic physics behind it, and the kinematics, this is an important thing which everybody must know. Because what I see is the vast majority of spinal operations, they're not, or should I say, the vast majority of spinal construct failures, they're not actual device failures. You see, very few wires break, very few screws break, very few implants come out. I mean, they are gross and few, but mostly they are related to surgeon errors regarding improper construct, improper selection of construct, and inappropriate patient selection. So I believe that if we all understand these principles and then think in your mind what exactly is wrong and then devise a treatment plan, I'm sure we will be able to treat our patients much better. Okay. So we are going to talk today about the vertebral column complex. Now, what does the vertebral column complex mean? What does that term mean? It means the vertebral bodies, the discs, the pedicles, the lamina, the facet joints, the spinous processes, the muscles and ligaments. And many times we just get lost in the romance of instrumentation and we forget the muscles and ligaments. And as we proceed with this talk, the idea of this talk is to remind you again that these muscles and these ligaments are extremely important, and unless you factor them in to devise a treatment plan, more often than not, the constructs are going to fail and the problem is going to recur or may in fact become worse. So let us look at these structures one by one. Let's see the vertebral bodies. If you see, for a spinal surgeon, these two dimensions, the depth, which is the anterior-posterior height of the body, and the width, which is the right to left or the side to side width of the body. These two are extremely important because then you can devise whether this needs a plate or a screw or rod or whatever you want to put there or nothing for that matter. And if you see that these two parameters, the width and the depth, they gradually increase from the cervical to the thoracic, gradual increase in the thoracic, further increase in the lumbar, that is the width. The bodies of the lumbar spine become bigger and bigger and bigger, and the lower lumbar ones are the biggest bodies you can find in the human body. While the depth of that is the anterior posterior height or the depth of the vertebra, that increases very gradually in the cervical spine, increases much more as you go down the thoracic spine, and then there is a kind of plateau, and then the lower lumbar, the actual height may be, the depth may actually be less. The L5 depth may be actually less than the L1 and 2 depth. So one must remember these things, where the cervical, it gradually increases, in the thoracic, it increases more, in the last lumbar, it actually decreases. So you must know these things. Otherwise, it will be very difficult to plan. Now, another important thing to know is the ventral and the dorsal height of the body. This is important because you must know how much space do you have so that a plate can be securely fixed to the body anteriorly? How much space do you have from the back, so that if your screws are going multiple screws, then you must know how much space do you have at the back. So these two heights are important. You must pay attention. Next time you pick up an X-ray or a CT scan which shows the whole body, you must actually see. So this, the vertebral body height in millimeters, the height means superior inferior, that actually decreases in the cervical spine. As you go down the cervical spine, the height of the vertebral bodies actually increase, and then it gradually increases in the thoracic and the lumbar. And in the lumbar spine, there is a difference between the ventral and dorsal heights of the vertebral bodies. One must remember that. Now, this loss of or the decrease in height results in decrease in calcium and decrease in strength. And that is reflected beautifully by this other graph over here, which shows the compression strength in newtons to the different levels in the body. So the cervical spine, the compression length strength is about a little less than 2000 newtons, while in the lumbar spine, you see the compression strength. It's almost up to 8000. That's 4 times the cervical spine or even more. And that is what the increasing in size does. It makes these bodies more strong so that they're able to bear the weight of the entire skeleton, entire body, which ultimately transmits through the spine and into the ground when you're standing. Now, as far as the cervical spine is concerned, one must know, there was a question, I was listening to the session before this, and I remember there was something about how to identify where is the vertebral artery and how do you keep it safe. So the two things important whenever you are attempting anterior surgery, for whatever reason you may be attempting, is to take care of the root and to take care of the artery. As long as you don't injure these two, I'm sure most things can be overcome and the results will be good. And these two, if you're going by the anterior approach, the most important anatomical structure which you must remember is the uncinate process. It projects from the rostral, dorsal, lateral aspect of C3 to C7, and it articulates with the caudal, dorsal and lateral aspect of the body above. And this has major things. It gives rise to coupling. It gives rise to the movement of the vertebra above or below when one vertebra moves. So coupling motion of the cervical spine is because of these, partly because of these uncinate process and the joint, the uncovertebral joint. Now, what is the function of this uncovertebral joint? It stabilizes the spine during axial rotation by coupling it to the vertebra above and to the vertebra below. And importantly, it is also the nidus for foraminal osteophyte growth. So more often than not, the foraminal osteophytes, they grow from near the uncinate process and the uncovertebral joint. So you must look at the CT scan or the X-ray carefully before you attempt anterior surgery. See what is happening to the disc, see where the uncovertebral joints are. Right behind the uncovertebral joints is the nerve root which exits through the foramen. And away from this, further lateral, is the artery. So if you're operating on the bone and you're well away from the uncovertebral joint, or you're careful about the uncovertebral joint, the root will definitely be safe. And the artery is even beyond that. So unless you're between two vertebral bodies where there is no bone to protect you, that is in the disc space, then you have to be extremely careful about the lateral extent of your discectomy so that you take care of the vertebral artery. Now, if you see the shape of the vertebral body, the cervical spine vertebral bodies are generally solid cylinder, but the surface facing the spinal canal is concave. It is concave dorsally. You see that? It's concave dorsally. So that gives you that extra 2 or 3 millimeters space. You see the spinal canal is inside, and because of this concave shape, you have this little bit, maybe a few millimeters of space, which is safe. So more often than not, the anterior screws, even if they touch the cortex here, or they come out by a few millimeter or 1 millimeter or a part of a millimeter, it is still safe. And earlier concept, when these locking plates were not available, we were always taught that go for a bicortical purchase. The screw should purchase the cortex here and the cortex here, so that you have a bicortical purchase, and the pull-out strength of the screw increases tremendously if you have a bicortical purchase. And this typical shape of the cervical vertebral body gives you that leeway. So that ventral spine operations become safe, especially the fixation operations, and the placement of screws becomes that much safer. That few millimeters gives you that adequate cushion. Now, if you know a little bit about physics, I'm sure most of us would remember that vector is a force oriented in a fixed and a well-defined direction in a three-dimensional space. So this is the A part of this diagram shows you what a vector is. It has the force and it has also a direction, a well-defined direction. Now, force vector may act on a lever. You know, you have heard of lever. The Archimedes famously said that you give me a place to stand and give me a lever long enough and I can lift the earth. So levers and the force vectors are very important principles, especially when spine surgery is concerned, because levers and the moment arm generated by these levers cause a bending moment. It can move things, it can bend things. So one must remember what our screws, plates, and all the interventions, what are they doing to these force vectors? What is happening? Is it producing a lever? And how big is the moment arm, etc., etc. One must think about these. So a bending moment is applied to a point, and then this moment will cause a rotation, and this rotation will be about an axis. The axis can be vertical, rostral caudal, or it can be in the other planes, that is right to left or ventral dorsal. So you have these three axes, the X, Y, and the Z, and the instantaneous axis of rotation is the center point where all these three axes meet. And as you can see, because of this three-dimensional space, which is around an instantaneous axis, the movement can occur in 6 planes in each of these axes, X, Y, and Z, whether it's towards the instantaneous axis or away from it. So you have these 6 planes where mobility or movement can occur. So this instantaneous axis of rotation is also very important. And when we stabilize or when we manipulate or when we rotate, the axis about which each vertebral segment rotates is the instantaneous axis of rotation. So you must remember, where is my screw going? How far is it from the instantaneous axis of rotation? How much rotation will I actually get? And this becomes important, especially in deformity. When you're correcting deformity or gross deformities, you must think about the instantaneous axis of rotation and how your appliances, your screws or your plate or your hooks or anything you're using, wires, how are they going to change the moment which is acting on the instantaneous axis of rotation? So usually the instantaneous axis of rotation in the spine, in a straight spine, it lies in the middle of the body. It lies somewhere around a few millimeters maybe in the middle of the body. So one must remember that. And the movement is going to occur at the axis is going to be the instantaneous axis of rotation. So whatever manipulation you do, whether anterior or posterior, one must not forget that the instantaneous axis of rotation is inside the body. So your moments and your lever arms must be long enough or strong enough to actually cause mobility at the instantaneous axis of rotation. And this instantaneous axis of rotation changes according to the shape of the spine. Whenever the spine becomes kyphotic, the instantaneous axis of rotation moves closer to the spinal canal. It is closer to the spinal canal. And when it is a lordotic spine, the instantaneous axis of rotation moves out. It moves outside anteriorly to the spine. So once you know where is your instantaneous axis of rotation, then you will think of which screw, where to screw, etc., etc. Now, as Dr. Goel has so beautifully illustrated, these facet joints are so important because they are crucial for understanding the anatomy and the treatment of the cervical spine. If you look at the facets in the different parts of the spine, in the cervical spine, the facets are oriented as if you are blessing somebody, Ashirwad de rahe ho. Remember that, this movement. This is the way the facets are oriented in the cervical spine. In the thoracic spine, if you look at the B part, the facets are like this, as if they are trying to hold things together from either side. And near the spinal canal, the facets medially are closer and laterally they are further away. So the orientation is this. And in the lumbar spine, it is just the opposite of this. The facets are this way. They are oriented completely differently to the thoracic spine. Now, what is the clinical importance of these facets? As you see, these kind of facets facilitate the gliding movements very easily, very easily. So you see subluxations in the cervical spine are much more common because of the peculiar shape of the facets. They are like this, so it can easily slip forward. And of course, the other anatomy, the body is not very strong, the muscles are weak, the ligaments are also not as strong as the rest of the spine. So everything facilitates forward and backward movement, the gliding movement in the cervical facets. While if you look at the lumbar facets, they are completely opposite. So this gliding movement cannot occur. So the subluxation you see in L5, especially in L5S1, because the orientation of the facet is almost in the coronal plane. The L5S1 facets are almost like this. So you see the forward movement cannot occur, and that's the reason, because the coronal plane of the facet at L5S1, listhesis doesn't happen as commonly at L5S1. It happens more commonly at L4, L5. That's because the slight decrease in the coronal orientation of the L4, L5 facets as compared to the L5S1 facets. So unless you have these basic principles in your mind, you will then make the appropriate choice and do the correct fusion, whatever is needed in your particular case. So this chart actually gives you the same thing in a graphic way, how the facet joint angle, that is with respect to the midline, changes in the lumbar spine specifically. And if you see, it gradually increases. By this, I mean this angle. It is very well shown in this graph. And if you see, the lower lumbar are almost 40 degrees. So the medial angulation is almost 40 degrees. So your screws have to go medially. So by nature, triangulation can occur very well if you just follow the orientation of the facets. Another important thing, these facets, especially in the cervical spine, they support the axial loads only in extension. Only in extension. If they are not touching each other, if they are far away, they will not bear the load. And by spacers, by putting in spacers, Dr. Goel has beautifully said how you can make those two facets touch each other so that they touch, and that's where the load bearing will occur. Otherwise, all the load will be onto the bodies and the discs, and which will ultimately fail. So one must remember, they're important. The cervical facets have to be in extension. They have to support the load. Unless they do that, your fusion is going to fail. It's not going to work. Sooner than later, it is going to fail. And the facet joints are loose capsule and a synovial lining. They're also called apophyseal or synovial joints. The rest of the points we have already discussed. So let's move. Segmental movements, I don't need to describe in detail to you. You know very well that the maximum movement occurs at C0, C1, and that's about 25 degrees. And the other one the axial rotation occurs at C1, C2, almost about 42 degrees. And that's why you can look from side to side and you can look above and below. Most of these actions occur between C0, C1, and C2. And as you go down the spine, the mobility decreases. And in the lumbar spine, again, the flexion extension increases a little bit, while the lateral bending and axial rotations decrease. Canal and the contents, I don't have to really tell about neurology to neurosurgeons. It's like taking, ulte baaz bareli ko. I'm sure you all know all these things, so I'm going to skip all that, except you must know that there is very little space in the thoracic spine. The thoracic spine is unforgiving, especially for tumor, trauma, or whatever is causing the spinal canal contents to be compressed. That's because the space is very little. While the cervical spine, especially in the top part, C1, C2, it's quite forgiving. There is a few millimeters of space inside the spinal canal. and so the dura and the contents are protected, more space there, while the thoracic spine is very little space. And in the lumbar spine, thankfully, the spinal cord ends and it's only roots. It's like hanging a bunch of noodles in a sack full of water or in a balloon full of water. It's just like that. So a little bit of pressure here and there really doesn't make much difference unless one root is getting trapped. So one must remember all these things when you're planning surgery. Now let's come to the pedicles, because our fixation today focuses more on the pedicles. Transpedicular. The advantage of transpedicular being that all three columns of the spine are being engaged when you put a screw from the posterior elements right into the body. So the posterior, the middle, and the anterior segment, everything is engaged by a pedicle screw, and that is why it is most stable, or it provides maximum stability. So one must know about the pedicles. In the cervical spine, they are very short. Proportionately, they have a greater diameter. And if you see the transverse pedicle width, that is this width of the pedicle, if you see in the cervical spine, it is just about 5, 6, 7 millimeters, not much space. So that is why you need experience. You need to know exactly how big is the pedicle, what is the direction. So putting a pedicle screw is a little bit difficult. While in the lumbar spine, look at the width of the pedicle. It's 17 millimeters, 18 millimeters. So there's a lot of leeway. It's quite forgiving. Your angle may not be perfect, but there's still enough space for your screw to remain inside the bone of the pedicle and still engage the posterior and the anterior columns of the spine. So one must remember this, that the thoracic screws are dangerous because the space is very little. You have a few millimeters, 5, 6, 7. And if you have a 4 millimeter screw, which is going a little bit haywire, you're either going to hit the cord inside or you're going to damage something outside. Okay, so the height. By height, I mean this, the vertical height of the pedicle. That is the sagittal width. It increases from cervical to the thoracic. You see this all down the thoracic spine, the height of the pedicle keeps on increasing. While in the cervical spine, it is more or less stable. Few millimeters, again, maybe 7, 6, 7 millimeters. That much is the vertical height of the pedicle you get. While in the lumbar spine, again, you have about 16, 17, 15 millimeters of height. So again, the angulation of the pedicle, the screw can be directed vertically downwards. It can be straight. It can be parallel to the disc. It can go towards the disc above or below. So all these things are possible more safely in the lumbar spine than in the cervical and the thoracic, because the early part of the thoracic spine and the cervical spine doesn't give you enough space. Your screw has to be only in that direction. If you have only 5 or 6 millimeters of bone available. Third is the angle at which the pedicles are attached. This angle which the diagram shows. Again, if you see in the cervical spine, this angle is almost 40 degrees. So your screw has to be directed 40 degrees medial. So if you want to put a pedicle screw, you have to expose that much more. Otherwise, you wouldn't be sure of your direction. Only when you have enough experience, you can probably get away without doing a lot of muscle dissection and without exposing all the bone to get the angle right. Or you have to drill away, you have to burr away some bone to actually see the pedicle and then engage, like what Dr. Abumi, his technique shows, that you burr away a little bit of bone and you can see the pedicle starting there, and then you introduce your screw in the right angle. Otherwise, that angle is very important. Again, this angle keeps on decreasing in the thoracic spine. In fact, in the lower part of the thoracic spine, it is negative. That means that it is actually lateral. The pedicles are going laterally. So one must remember that in the lower thoracic, you don't have to be medial. If you are medial, you may damage something. The thoracic spine, the rule of the thumb is go straight or you go outside in. You go completely outside. You go outside this. You engage the transverse process. You go out over here, and then you engage the body. The in, out, in technique, that is a safe, and that is especially for beginners, for people who are still starting their career. The in, out, in technique is much safer than if you want your entire screw to remain inside the pedicle, because the thoracic pedicles, especially in deformity, can be tricky. They can be really tricky. And remember, the angle in the lower part of the thoracic spine is almost negative. So you can go dead straight or you can go slightly outwards laterally. And finally, for the pedicles, the angle, the vertical angle at which the pedicles are attached. If you see in the cervical spine, this vertical angle is actually negative. That means the pedicles are actually going upwards. They're actually going upwards. And that's why the cervical pedicle screw have to be medial, they have to be upwards, etc., etc. And that's the reason they are more dangerous. While in the thoracic spine, you have these almost up to 15, 16 degrees. So it has to be directed downwards because it's pointing downwards. And in the lumbar spine, again, it decreases. And in the last lumbar vertebra or the sacrum, sometimes it can be negative. So remember that. The vertical angle at which your screw is going, you must remember that. In the cervical spine, it has to go upwards. In the thoracic spine, it has to go downwards. And in the lumbar spine, you may be straight. But there is enough space in the lumbar spine. So all these things usually are much safer in the lumbar spine and the sacrum. While in the cervical spine, it is dangerous because you must remember this negative angle. So it is upwards. The pedicles are actually joining upwards. Thoracic pedicles, there is enough literature available. You can all refer to any one of the techniques to find the thoracic pedicle. Not very difficult. What I usually do is to at least bear a little bit of the facet over here. You should have the transverse process in view, and then you follow the same principle. That is a line drawn at the base, a line bisecting the transverse process, where these two, or the line outside this facet and the line bisecting the thoracic pedicle, where these two lines meet. Usually that is where the pedicle is. And then depending upon whether you want to use the in-out-in technique or you want the whole screw to be inside the pedicle, you can use one of these techniques. Now discs, you all know this, annulus fibrosus, the nucleus pulposus. One thing you must remember that whichever side the axial loads are applied on the spine vertically, the nucleus pulposus moves to the opposite direction. So one must remember that. So if you have a disc prolapse on the right side, that means there was some axial compression must have happened on the left side. One must remember that. So you should know these things so that you look at the things properly. You look at the facets on either side, which way the disc has prolapsed and what is happening to the other side. One must think about all these things. So let me just skip over all this. So this is important. The annulus and then the nucleus pulposus moves to the opposite direction. So the transverse processes, they are important because they are important anatomical landmarks. They attach all the paraspinal muscles. They allow leverage for the lateral bending. They are very small with poor vascularity. They can be easily fractured. If you push and pull too much, the transverse process can break. And then you lose a good anatomical landmark and a fixation point. But as you go down the spine in the lower thoracic and the lumbar, you have good sized lateral and upward transverse processes. While the lumbar transverse processes are much more ventral, they're much deeper. So if you're going from a posterior approach, remember the lumbar transverse process you're going to find under all those thick and big muscles. And I'm going to discuss the muscles in a short while. So the lumbar ones are much more deeper to access. Remember that. And in the upper cervical spine, C1 to C6, one must not forget the foramen for the vertebral artery and the juxtaposed uncovertebral joint. You must not forget these two important anatomical landmarks. Now, these are the ligaments which you can have in the spine, the anterior and the posterior longitudinal ligament, the intertransverse, the interspinous, the facet capsular ligament. Many times we forget, and while doing the dissections, we just damage the facet joint capsule indiscriminately, even at the level above and below which we are not going to fuse. Please do not do that. Please conserve the facet capsular ligament. It is a very important ligament which contributes to the stability of the spine. In fact, this graph over here, which says the failure strength of spinal ligaments, and if you see this, you will find that the capsular ligament, which is these kind of hashes, it is so important. You see, it contributes so much in the lumbar, in the thoracic, and in fact, in the cervical ligament, the capsular ligament is one of the most important ones to contribute. So if you are not going to fuse a particular vertebral spinal motion segment, please do not damage the facet joint capsule of the joint above or below. Please do not, depending upon whatever. because you're contributing to instability. So remember that, how important these ligaments are. The solid black ones is the anterior longitudinal ligament. It is very important, especially in the thoracic and lumbar. And in the cervical, the most important is the capsular ligament of the facet joint. Please remember that. Please remember that. And now, if you remember the instantaneous axis of rotation, how levers act and how they produce a moment which has a bending arm, now you will understand what is the importance of instantaneous axis of rotation. If you see how far these ligaments are from the instantaneous axis of rotation, then you will understand why they produce that much more mobility. If you see, the interspinous ligament is the furthest away, and that is why it contributes stability because of its long lever arm. The next furthest away is the capsular ligament again. So these ligaments are very important even by the principles of physics. The moment or the lever arm produced by the moment applied from the capsular ligament is much more, it's further away. It can produce more movement while being far away. So that's how important these capsular ligaments are of the facet joints above and below, and especially in the cervical spine, and one must remember to protect them. You can go to great lengths to save them. Your dissection should not be with the monopolar. You just denude the bone and remove every soft tissue which you see. That should not be the way. Use a Cobb retractor. Move the muscle away. Let the ligament remain. That's the way to do safe surgery. So all this is about how the ligaments break and how much strength these ligaments have. Every ligament has an elastic zone. So as long as you're operating between this elastic zone and the neutral zone, you are actually doing some benefit, some work. Beyond that, it will break. So it will go beyond the physiologic range of motion. So it's not going to be useful. There's no point breaking ligaments which are healthy. Very important concept, muscles. The erector spinae is for extension and lateral bending. The psoas is for flexion. The rectus abdominis is for flexion. And there is a continuous dynamic influence which limits the size of the neutral zone and it increases the stability. The neutral zone, when it is wide, that means a lot of mobility can occur. But if the neutral zone is narrow, that means the spine is more stable. And these anterior and posterior group of muscles, they actually influence the spine from the front and the back, and they limit the size of the neutral zone. And in the thoracic spine, remember, the rib cage and the sternum anteriorly is a major spine stabilizer as far as the thoracic spine is concerned. Now, there are so many muscles which contribute to the spinal stability, but one important muscle, you always talk about erector spinae and this and that. You must not forget the multifidi, the multifidus. It is one of the most important muscles which contributes to the spinal stability. And where is this multifidus muscle? This one in the red. This is the multifidus muscle. If you see, it has so many different branches or so many different parts. Almost every vertebral segment from C4 to the sacrum is attached by the multifidus. And what does it do? It stabilizes the spine. If you imagine the spine as being a stack of marbles, marbles, so very unstable, spherical, on one on top of the other, then this multifidus attaches these individual marbles to each other. It is so important. It contributes to stability in a major way. And when you dissect indiscriminately and you destroy the multifidus muscle, especially bilaterally and over multiple segments, you are contributed to instability in a major way. And what happens in spinal degeneration? If you see at the MRI picture here, this is fatty infiltration of all the muscles, including the multifidus. This is what is degeneration. This is what is spinal degeneration. And everything else follows after these muscles become weak. So please protect these muscles. And there are beautiful exercises available. The physiotherapy, we totally forget in our glamour and in our, romance of fixation, etc., we forget the muscles. The muscles are the most important ones. They become weak and then the spinal instability follows. So if you maintain your muscles properly, including the multifidus, you can prevent a lot of degeneration and a lot of instability of the spine. So what is multifidus? These are these cross attachments from spinous process to the transverse process of the vertebra above and below. These crosses, which cross and fix one segment to the other, and they are at multiple levels from C4 to L5 or even up to the sacrum. That's how important they are. Just remember this, marbles, one on top of the other, and something holding those two marbles, fixing each marble with the other, and couple everything together, and that's how it becomes stable. And if you remove the multifidus, well, it's not good. It's not good at all. And multifidus, these muscles start acting even before. The moment you think that, okay, I'm going to bend forwards, it's the multifidus which has to start acting even before you actually bend. Because while bending, what is going to stabilize is all these muscles, including multifidus. So multifidus action starts even before the actual action begins. It starts here, here. And we as surgeons also should think from here, here, not from our spine, but from here. We must save the multifidus. And it's never talked about. Nobody talks about multifidus. Nobody talks about this, but this is the most important muscle. At least I believe so, that multifidus is the crucial one. You save the multifidus, and you save a lot of instability of the spine. The bones, the ratio of the cortical to cancellous bone is important. One must know where is cancellous bone, what is cancellous bone. Cancellous bone is the marrow, the red, crumbly bone which you find inside a vertebral body typically. The cortical bone is the thick, white, bloodless outer layer of bone which you find on a vertebral body. This ratio of cortical to cancellous bone is greatest in the pedicles. There is a whole lot of cortical bone in the pedicle. That's why pedicle screws are more important in stability, because cortical bone can take the screw, or the thread of the screw lodges in these cortical bones, and that's how it makes it safer. While in a cancellous bone, your screw will be floating, or in no time it will pull out. So you have to have cortical bone for fixation. And that's why a pedicle screw is more stable, because of the inherent anatomy of the pedicles. There is more cortical to cancellous bone ratio in these pedicles. And whenever there is osteoporosis, remember the bone density decreases by 50%, 50%, and then 75% decrease in strength happens by that 50% loss. So osteoporosis can be dangerous. You may think, oh, it's not too bad, but remember this ratio, 50% loss in calcium, 75% loss in strength. Remember that. It's not one-to-one. So osteoporosis is a very important factor you must remember when you are trying to fix one bone to the other. We have discussed this, how the lordotic posture or the extension of the cervical spine makes the facets come closer together. That's how they become load sharing. They will take the load off the body in the anterior part. And that's why Dr. Goel's idea has immense merit in the principles of physics, because you have to make them load bearing. Once you make the facets load bearing, you're going to take the load off the vertebral body and the discs. And obviously the degeneration is going to slow down, or in some cases even reverse. So there is physics principles wise and the biomechanic principle wise, there is merit in the idea that facet joint is the key. No doubt about it. It will definitely share the load from the disc and the body and slow down or prevent degeneration. Okay, so we know this principle of this tension band from the back. You know where the instantaneous axis of rotation is. You know how far is the interspinous ligament. It is a very big contributor to the stability, and that's why the tension band is so important. We rarely discuss about the tension band, but one must learn how to operate on either side of the spine without destroying the midline tension band. We must learn it. These are one of the key principles to learn from our orthopedic friends. They keep talking about these tension bands and we think, oh, pata nahi kya bol raha hai. जाओ वहां पे सारा निकाल दो, सारा बोन दिखना चाहिए ऊपर से नीचे तक, फिर स्क्रू लगा दो. अरे भैया, वो मिड लाइन टेंशन बैंड बहुत जरूरी है. It contributes a lot to the stability, and you can operate on either side of the spine without destroying the midline, without destroying the midline tension band. So remember it, that tension band is very important, especially in the cervical spine where everything is so small and weak. Thoracic spine, we have already discussed, it is shielded by massive muscle mass of the thoracic cage. So you need a lot of energy to fracture. So if there is a cervical or a thoracic spine fracture, you must look at the whole body from head to toe. There must be more fractures because it needs a lot of energy to fracture a thoracic spine. So more often than not, these dual fractures or dual injuries are seen in thoracic spine fractures because you need a lot of energy to fracture. And of course, as we discussed earlier, the canal is very narrow, and that's why, because of no space, even a small injury can give catastrophic results. And that's why this thoracic spine causes paraplegia so many more times than cervical or even lumbar spine. But lumbar spine is good because there is no spinal cord, it's only the roots. And that's why this all or nothing risk of neurological injury is much more in the thoracic spine than the other parts of the spine. Another important thing, one must remember these junctional areas where the cervical spine meets the thoracic spine, because the curvature is entirely different. The cervical spine is like a C, while the thoracic spine is kyphosed, and the point where these two meet, that is a vulnerable area. So you should not leave any fixation hanging at C7. You should go down to the thoracic spine and include one or two levels of the thoracic spine also. Or in the lumbothoracic junction, thoracolumbar junction, don't stop at T12. Go into the lumbar spine, because these junctional areas are very important, and your construct failures will be much more if you leave the construct hanging at T12 and not cover the junction by going down up to L2. Or in the cervical spine, if you stop at C7 and not go into the thoracic spine, well, the C7 T1 junction many times is going to be more vulnerable than before. Lumbar spine has large bodies, lordotic posture. There is no cord, it's only the cauda equina. So catastrophic spinal injury from trauma is much less likely. Again, lumbosacral junction, we already discussed this. How the LS joint is almost vertical, it's in the coronal plane. So usually the mobility is restricted. And so listhesis occurs more frequently at L4, L5 than at L5, S1. That little bit away from the coronal plane of the L4-5 joint makes it more vulnerable than the L5-S1 joints. So one must remember the facet joint geometry, the angles at which it is attached, how to find the facets, and then you will not go wrong To address this question of stability and instability, there's nothing beyond White and Punjabi, and it is the most extensive study on spinal stability, but it is very cumbersome. It is very cumbersome. They have calculated a lot of things, points. So you don't have White and Punjabi abridged version which you can apply on every case in the clinic, in the OPD, or in the emergency room. There is none. And every time you can't go back to White and Punjabi and give points. So you need something better than that. And that's why this concept of anterior, middle, and posterior columns of the spine, and it works reasonably well. And the second one is the AO spine classification, which now takes care of neurology as well, which is a welcome addition. Otherwise, our orthopod friends used to just think bone and not think soft tissue. But now the latest additions include both. So you can follow the AO classification to find out what is unstable, what is stable, what surgery to do, when to do. And that AO latest classification addresses these problems quite well. These column concepts is working fine, the anterior and middle and posterior. And the pedicle screw engages all three columns. It starts from somewhere here, posterior column, middle column, and goes into the body, into the anterior column. So, so this column concept, whichever concept you use, I use this 3-column concept, it works very well, or you can map it onto the latest AO. That also works quite well. To decide, especially in thoracolumbar injuries, or injuries, or even for tumor, they have a classification now. The neoplasia stability score.
Kale, sir.
So this is the White and Punjabi. It's quite cumbersome, big. You can't do that. Then there is an acute overt instability, limited instability, usually a true burst fracture, ligamentous injury, facet fracture. They are all limited instability problems. And finally, there is this chronic glacial instability, which happens in those lumbar listhesis. There is no overt or rapidly progressing, but gradually it keeps on progressing. And you can see horrendous, even up to spondyloptosis, where the L5 actually is lying in front of S1, or L4 is lying in front of L5. And the patient may be clinically absolutely fine, except for some back pain. Usually they don't have much problem. So addressing these chronic glacial instability problems can be tricky. Anyhow, so I think I should end over
Yes,
here.
sir.